Fashionably late to the party, turning our nation's reluctance to embrace national health care into a strength. Though America is the last industrialized nation to adopt national health care, if we can analyze our predecessors with intent to improve upon their success, our tardy beginning can result in quite a fashionable entrance to a productive and universal care model that will benefit us all. So why focus only on England and Canada? Well, both are ideal sources to study for two reasons. One, they are both English-speaking first world nations and share many similar values despite differences of political system. And two, both have turned to universal health care for their citizens for decades now. So there are seniors in this pursuit. In this digital story, I will compare their systems and then give an overview of the conclusions I've come to through my researching the topic in more depth. Data shows that Canada and the UK spend less on healthcare overall, spend less per person annually, and yet manage to have a lower percentage of preventative risk factors like obesity. Though it should be noted that we are a more populated country, but also too that their expenses cover all their citizens while our much larger sum only covers a fraction of our own. Though no system is without issues, there is much we can learn from England and Canada about the crucial components of a healthy system. So let's begin with our neighbor Canada. The Canadian health system focuses on being able to receive hospital care and services medically necessary. It's funded through taxes and operates its insurance program with no cost sharing. Though despite how I'm referring to it for the sake of simplicity, it's an important distinction of the Canadian system that there isn't actually a single system. Instead, citizens are covered by Medicare, but the provinces provide the medically necessary services and decide whether or not to provide for additional benefits. Benefits like prescription drug coverage, home care, dental care, ambulance services, vision care, and independent living aids. 2/3 of Canadians purchase supplemental private insurance to meet these needs, but insurance that covers the same services as the province's plan is not allowed. That equates to 30% of health benefits coming from private services in the Canadian healthcare system. In 2009, Canada spent 11.4% of its gross domestic product on healthcare, compared to our 17.4%. This has much to do with lower unit costs of itemized procedures, lower administrative costs, and controlled prescription prices and physician fees per service, which account for the vast difference in prices for the same medical procedure. Here, one example, an MRI in Canada costs approximately $824, compared to an MRI here in the U.S., which is $1,200. Canada also has impressive survival rates for breast cancer and colorectal cancers, and does well with primary care, preventing costly hospital admissions from chronic conditions like asthma and uncontrolled diabetes. But valuing necessity above consumerism can cause tension as well. Due to controlled hospital costs, the use of high-technology diagnostic and surgical procedures can result in waiting lists for certain specialty care services. However, emergency cases are treated immediately, overriding those lists. Though it isn't fully clear the extent to which waiting times are an issue, but it remains a popular voice concern with this system. Current attempts in effect to improve efficiency are: the Canada Health Infoway is working to accelerate the adoption of electronic health records, often referred to as EHRs. The National Pharmaceutical Strategy is addressing the challenges concerning affordability, safety, and evidence-based value of prescription medications. And the Canadian Agency for Drugs and Technologies in Health is advising the government on clinical and economic viability of emerging health technologies and optimal use. What Observing Canada teaches us is the efficiency and cost-effectiveness of universal access, uniform payment systems and expenditure controls, and in more detail, that universal coverage that isn't dependent upon employment, having single payers at the local level handling reimbursement, negotiating hospital budgets, drug costs, doctors' fees, and regulating expenses of equipment and services lends to increased accountability, instead of a numerous payer system where procedures and coverage vary so wildly that no one bears responsibility for the entire system. The UK healthcare system is also provided by a single payer, the National Health Service, or the NHS, a division of the British government. It's financed through taxation and requires minimal cost sharing for services like optometry care, dental care, and prescription drugs. The NHS budget is controlled by primary care trusts, or PCTs, which contract with physicians and hospitals to provide care for a geographic population. Britain ranks above the US in most health measurements. Its citizens have longer life expectancy, lower infant mortality, more acute care hospital beds per capita, and fewer deaths related to surgical or medical mishaps. Very impressive, considering that the NHS spends an average per person of $2,500 a year, compared to our $6,000. The system is based upon the belief that everyone is entitled to health care free at point of service, and that everyone has a responsibility to care for their fellow man. They're strong supporters of regulating profit, not prices. Where the drug industry is concerned, companies are required to submit financial records and by determining set proportions for expenditures on inpatient branded drugs. If prices result in higher profits than allowed, the excess profits are paid back, both ensuring and limiting profits. And providers and hospitals are given drug budgets that make abuse and careless prescriptions when not necessary less likely. There are also systematic appraisals of new technology and centralized administrative systems that result in lower overhaul costs. The British government sets the budget for the NHS on a 3-year cycle to control costs and capped overall budgets for primary care trusts, and they're expected to achieve financial balance each year. Private health insurance exists in the UK, similar to the way it does here in the US. Some employers offer private health insurance as a perk, and some employees will choose to opt out of the NHS system to receive medical care privately. Drawbacks to the NHS system are wait times for elective procedures like cord removal, breast reduction, or LASIK surgery. Also, continuing to limit expenses for the sake of a sustainable system often results in the avoidance of pricey drugs and therapies and slower adjustments to advances in medical technology that can lead to less treatment flexibility and early screening for cancers. Cancer treatment is one area where British patients receive inferior treatment compared to the fraction of Americans who have comprehensive health insurance, therefore no waiting lists and access to a greater range of therapies. There are a number of organizations and policies to address the above issues, ensure quality, and improve efficiency of the NHS system. I would like to focus on the Nation Service Frameworks. These are guidelines that set national standards and identify key interventions for defined services and care groups. It seeks to accomplish this task through a focus on quality contracts. The Commissioning for Quality and Innovation payment framework requires contracts between commissioners and health service providers to include causes making a proportion of income conditional on quality and innovation, also through a focus on quality and outcomes. This framework measures the quality of care delivered and provides incentives for improving quality. General practices are awarded points that determine payments based on the practice's efficiency, patient experience, and extra services offered, like child care and maternity, and degree of success in managing common chronic diseases. Quality accounts. All providers produce quality accounts reporting on the services they provide, documenting safety, effectiveness, and patient experience. Overall, England offers us a vast amount of insight that reforms long thought impossible are not only possible, but offer proven dynamic gains from their pursuit. Britain's methods of stepping in to control costs, especially that of prescription drugs, service fees, and streamlining administrative costs, while rewarding care providers for results, is an invaluable lesson about promoting holistic care. After considering these two nations, I've learned the following are major aspects to a superior healthcare system. 1, healthcare should be free at point of service. Medical services, with as little cost sharing as possible, encourage patients to practice preventative medicine and inquire about issues early when treatment will still be light, instead of avoiding physicals and other preventative measures due to costs. 2, establishing a strong focus on primary care and providing financial incentive for physicians to meet the needs of underserved communities or patients whose care is more demanding, and rewarding them with bonuses based on quality, comprehensiveness of services provided, or for reaching prevention goals. And 3, that the use of strategies for controlling costs work. Things like creating a national board that negotiates with pharmaceutical companies and rewarding breakthrough research while discouraging Me Too research or patent manipulation. leads to savings. I strongly believe if we can incorporate these principles along with maintaining some of our current strengths as a nation regarding healthcare, namely number of patient options and care flexibility for patients, while continuing to invest in and value medical research and medical innovation, that it will result in dynamic improvements in how we fund, distribute, and improve the wellness of our people. I look forward to seeing our coming National Healthcare Act fully operational, because it seems I'm not the only one who's been paying attention to the strategies beyond our borders, and I have high expectations for its success. That concludes my presentation. Thank you for listening and your time.